This is the Shelbourne Knee Center podcast. This is Dr. Benner, and we're here tonight talking about an interesting topic to our office that we've just started using this year, robotic assistance for total knee arthroplasty. And I have my own short experience here that's just been since the first of the year. We've done about 150 of these cases at our center, but we wanted to bring on someone with a little bit longer experience than I have. So tonight, Scott Bauman is here with me, our co-host. And also we are hosting tonight Dr. Jim Ballard. Jim is from Portland, Oregon. He is from Rock Orthopedics. If you want to hit his social media to check it out, Rock_Orthopedics is his Instagram handle. And then you can also see him on Facebook as well. He also has a website that is jamesballardmd.com. And you can visit all those to check him out. So Jim, thank you for joining us tonight. And it's a pleasure to have you.
It's great to finally be on with you guys.
Tonight, we're going to be talking, like we said, about robotics. And robotics is it's new to me anyway. It was something that was presented to me probably 3 or 4 years ago. And to be honest, I was very resistant to from the very beginning and told my reps when they were pitching this stuff to me, you know what, this is an uphill battle. I don't think this is probably for me. And they, like happens a lot with people from industry that were having discussions about new things. Over time, they kind of just chipped away. And I started reading a little bit more about this and hearing a little bit more about this. And, kind of slowly increase my level of interest. And like I said, I just started at the first of the year doing robotic total knee cases. And so let's just jump right in here, Jim. How long have you been using robotics? And kind of tell us a little bit about your arthroplasty practice.
Yes, I've been in practice for 20 years. So I started here in Portland in 2003. And that was way at the beginning, the early days of navigation. So my robotic involvement kind of has starts and stops as my career has gone on. So for some reason, the Northwest was a hot spot for navigation in the early 2000s. And I know navigation is not robotics, but it's certainly the beginning of robotics, right? Because every robotics platform is an advanced navigation unit. So I got involved in navigation. And the first navigation unit I used was from this company that Smith & Nephew ended up purchasing called Plus Orthopedics. And crazily enough, back in like 2004, this was a passive robotics mixed navigation unit called Pi Galileo. Have you ever heard of it?
I have not, no.
Probably haven't. So you would put a clamp on the femur, like right at the metaphyseal flare, and the clamp provided a stationary location for this robotic arm that you would clamp in. I'm sorry, a little motorized unit you would clamp in, and then it would move the cutting block passively to make all the cuts. So a little bit similar to what you and I use now with ROSA. So that, that was taking navigation and then just determining, neutral mechanical axis, making sure all the cuts achieved that because we were all after neutral mechanical axis back then. That was kind of cool. I mean, it was a novel technology. It didn't incorporate soft tissue at all. So it didn't really focus on, balancing or achieving equal gaps like what we're all focused on right now. But I was telling Scott earlier that yesterday I saw a lady back like 17 years later, and that knee looks like I put it in yesterday, which when you think about it's old polyethylene and all that, I mean, that's kind of cool. So it's a testament that stuff worked back then. I moved on to just straight navigation with Stryker for a long time. Then I just moved into regular standard instruments. Mako eventually came along. This was pre-Stryker, purchasing Mako, and I hadn't been really taught unis very much in my fellowship or my residency, so Mako was all unis back then. And so I went, to Northern California and learned on Mako, and my hospital bought a Mako, and then the Northwest being what it is, I mean, Mako exploded up here in Washington, in Seattle and Portland, and I learned how to do unis on a Mako, and it was a really nice machine, and used that for a while. Then Stryker purchased Mako, and then Rodney, what you said came into me. I got very frustrated with robotics. I didn't like all the promises, and I thought it was being overhyped. I just didn't know how it was going to really be good for total knees, and I was being told, like you mentioned, the reps kind of chip away at us, right? And the Stryker reps were telling me like I was going to be able to do total knees if I didn't do robotics, and I just shut my mind off to it and just told them to go away. And I really became a robotic skeptic and wanted nothing to do with it again. It's kind of weird, right? Because I started early on, I'm adopting this technology in the early 2000s. And then for reasons that didn't have much to do with science. I just got socially tired of what they were telling me. And so I just kind of told them to go away, you know.
It's interesting how we do that, isn't it? As orthopedic surgeons, we're like, oh, why am I doing this? I want to do something different.
Yeah,
to be honest, that's something that I felt like I had to fight for a while when I did become interested in this. Am I really interested for the right reasons, or am I just interested because I'm getting bored with what I'm doing right now? And I'm much less of an early adopter than it sounds like you were earlier in your career. I've been in practice for 11 years. And I trained under Gil Scuderi at the Insall Fellowship, what I consider pretty old school, bread and butter knee arthroplasty, and that really was right up my alley. I like reproducibility. I like not having to fiddle around with things, and that stuff was all really interesting for me. So when we started to think about robotics, I had to stop and think for a beat, like, am I doing this for the right reasons? And eventually the answer was yes. But I hear you on that that we go through phases. It seems like all of us do. I think where we get bored every once in a while. And it's tough. It's a tough creep that you have to kind of guard against from time to time, I guess.
I just didn't like people telling me that I wasn't going to be good without it.
Uh-huh.
You know what I mean? I didn't like being told that I needed it. And I was like, you know what? Sorry, I don't need it. And so then what's funny is I switched my knee implant system to Persona, which is sold by Zimmer, and I fell in love with the system. And then Zimmer started calling me like they called you and like, hey, you should look up this robot system we have called Rosa. And I just told them to go away. I'm like, I told them I wasn't interested. I didn't want to know anything about it. And time went by, and then some of my buddies that I know through Zimmer started to use it and started to talk about it. One of my buddies was using Mako and was talking a lot about it. And then one thing led to another, and I found myself in a lab in Arizona, kind of reluctantly. I mean, I think I met you at one of your first labs for Rosa, and I was very reluctant, and I was open-minded, but not really. And then my interest just kind of peaked, and eventually I ended up with a Rosa at my surgery center. So to answer your first question, that's a long answer, but that's how I kind of weaved my way where I am now. And what's hilarious is, Rodney, I started using it really because I wanted to have some meat on the bone to go back and tell Zimmer why I was right and why I didn't need it. Because we placed it, I didn't. I've
heard myself say those exact words a couple of years ago. Yes.
Yeah. I'm like, I'm just going to tell you guys why this isn't necessary, but I want to have 40 cases under my belt so I have some substance. And then it just all went in a completely different direction once I started getting into it. I mean, I couldn't have been more wrong.
Well, let's go back in time then to your experience with navigation and kind of set that scene for before you were really into a true robotic platform where you were doing mostly just computer navigation for total knees. From my perspective, one of my early hesitancies with the advent of robotics was I felt like when I reviewed the literature from computer navigation, it seemed to be pretty settled science, in my opinion, that it decreased the incidence of alignment outliers, that it was pretty clearly showing us an advantage with getting to our mechanical axis and alignment targets that we wanted to. It also seemed like equally settled science that despite that it didn't seem to make a difference in patient outcomes. And for me, I cared a lot more about patient outcomes. When I think about alignment, and I'll get a little bit of a soapbox here. We look at Merrill Ritter's data talking about how they had higher revision rates in people who had alignment outliers. We have Mark Pagnano and the Mayo Group's data that showed that the alignment outliers didn't do any worse from an alignment perspective. And then we have people that are, I think, more total knee purists like me that are still trying to stick to my parallel and perpendicular perfection ways, and people who are telling me, Steve Howe, people like that are saying a little bit of constitutional variance. We want to leave it a little bit this way, a little bit that way. So in the final analysis, my thought was, okay, so we can't decide what our target is. We can't decide whether or not it matters or not if we hit our target, because there's data that shows us yes or no each way. So the only reason I'm going to be interested in this is if it can make my patients better in the final analysis. And it just seemed to me like it seems like equally settled science that just isn't the case. So from my perspective, I know how I dealt with that. But when you have that same kind of stuff available to you, I'm sure, and you probably thought a lot of those same things. What was it that started to make you think that it could be helpful for your patients?
Well, like you, I started going, now, wait a minute. So if the idea is neutral mechanical alignment, like that's what you and I were raised on, right?
Mm-hmm.
That was like the 11th commandment. I mean, you put people at neutral plus or minus 3 degrees, right?
Mm-hmm.
So if you did a case and you fell within three of valgus, 3 of varus, which is a 6-degree swing, then you get a gold star, right?
Yep.
And you're like, okay, I'm awesome. I don't have an outlier, whatever. And then when I started going, but wait a minute, it's not affecting outcomes really. So that's why I went away from navigation. I'm like, I don't think it's I did it. I wasn't taking a super long time to do the cases, but I'm like, I'm not making a difference. I went back to standard instruments, nothing changed. Now, kinematic alignment came along and most people thought he was nuts, right? I mean, and just dismissed him. And then people started going, wait a minute, there is something about that. And at the same time, I remember maybe it was about 05 or 06 when I was like, okay, every person wants to be not every patient wants to be in neutral mechanical alignment. Some people want to be in some varus, some people want to be in valgus. And when I take a person that might want to be in 4 degrees of varus and smash them into neutral, it makes sense that their knee would hurt. And the same would go for a valgus knee. But I remember thinking, I have no idea where they want to be. So because I have no idea where they want to be, I'm going to jam everybody into a neutral alignment. And to me, the difference with robotics of this generation, and it isn't just ROSA. I mean, I think ROSA is a great system. I think the knee that goes with it is wonderful, but it isn't just ROSA. Robotics, if they're used to their potential, I think get us closer to the answer of maybe knowing where somebody wants to be and putting them where they want to be. Now, I'm not a kinematic guy, so I wouldn't say what I do is kinematic, but it's more of a, people are calling, but we have multiple names for it. Some people call it restricted kinematic. I think that's insulting to the kinematic people, hybrid alignment, whatever. But to me, the big thing with robotics is being able to play in the varus valgus alignment realm to some degree, maybe 4 degrees in each direction, and finding out that people did much better when I did that.
Well, I thought for me, when I got to the end of that and was thinking that and thinking, you know what, I don't think robotics is for me. What changed it, I think, for me is a little bit of shifting my own paradigm of just thinking about coronal alignment all the time and seeing in practice how many people would come to me with bad total knees done elsewhere that had 15 degrees of posterior slope. Like, oh man, that looks perfect on the AP view. Wow, the posterior slope is way off. Or people that would come in anterior slope with anterior slope of the tibia. And a big one for me is component rotation, which that's one I feel like the system is really good at on the femur. And it really doesn't even really address on the tibia, which I think is unfortunate, because I believe that that's the most important alignment parameter that people get wrong in 2023 is tibial component malrotation and internally rotating tibias. So, but I like that it wasn't just focused on coronal plane alignment. It allowed you to play with posterior slope. I tend to put in a little more posterior slope than the average surgeon. Probably I'm more like a 5 to 7 guy as opposed to 3. Norm Scott, when I was in fellowship, I felt like did a little bit more of that, and I really liked his technique in that regard. And then also being able to quantify the ligament balancing piece, which I think we'll be able to talk about a little bit later, was something that was really interesting.
Yeah, and also this goes along with something that you just said, getting more information, like you said, on sagittal alignment, so slope, and then you get into from a component rotation. I was born and raised, and I think so were you, as a measure resection guy. I didn't know anything about gap balancing when I got out of my fellowship. And when I started using their Persona system, maybe 4 years, maybe 5 years pre-ROSA, I converted to gap balancing in 1 OR day. Like they have a balance, so I use it, and I suddenly started. It's like my mind opened. I went, oh my gosh, I can play with femoral component rotation and create balanced flexion gaps. Where with measure resection, you're stuck at 3 degrees relative to PCA, and you can't affect flexion gaps. And so I started getting rid of the idea, to what you said earlier, paradigm shift, and being open to moving the femoral component in and out of the flexion space and rotating it. And that was an epiphany I had pre-robotics that I took into robotics that made a huge difference for me. And to go back to what you said before, the tibial component rotation, there's no doubt of the revisions I do, which I do a fair number, are almost all young knees. Like I'm not revising a bunch of disasters that are 25 years old. They're
Agreed.
4 years old, and almost all of them have tibial rotation errors. And so that's very common. And, a lot of that comes from symmetric base plate design. It's a lot easier to avoid that with an anatomically designed tibia, which gets into the ROSA system, but I'm sorry, the Persona system.
Yeah.
So this answer, the answer to this question may be different now than maybe it was, 3 years ago, or whenever you started on this ROSA system, when you said you wanted to get those 40 cases and almost wanted to prove why you didn't need it. I can go the other direction. Why do you feel like you need it now? And is that answer now any different than when you're first starting out?
Yeah. So as I started trying to prove it wrong, I was having these these consecutive days where one day I would do ROSAs at my surgery center. Then I go to the hospital and I would do standard instrumentation. And I started to see that I was the visibility that ROSA gave me on the gap, quantifying the gap, the medial lateral gaps and flexion and extension that I didn't have with my eyes, being able to plan the cuts ahead of time and predict what I'm going to end up with the cuts. I concluded that I was doing a better knee with ROSA than I was without it. And it put me in a bit of a moral quandary because I was like, man, I don't think I'm doing as good of a case for this person at the hospital as I am for this person at the center. And so I went to my CEO of my hospital, and 2 months later we had a ROSA at my hospital because I told him I needed it. So a lot of total knees that we do can be done very well with any technique you pick. And I think Rodney would agree with this. Measure resection, gap balancing, kinematic alignment. People I don't know what the number is. Let's say it's 80%. But then there's always a weird case that you get when if you're just cutting the bone without an eye on the prediction that the robotics gives you, where you're like, crap, like my gaps are imbalanced. What do I do now? The bones are cut. Oh no, I've got a poly that's 18. How did I get here? And knees can be really, really different and really odd. Like Rodney, I'm sure tell me, have you noticed, and I know you've noticed this, where you find a knee that on the x-ray is in varus, like you're setting up and look at your film, it's in varus, you go through all your evaluation with ROSA and it's really kind of loose medially and it's not behaving like a varus knee. And you're like,
I see that in flexion. I see some that are loose medially with valgus and flexion, which is something that I never even checked before. And to be honest, a lot of times I ignore it now. That's one thing I'm getting ahead into research, but one thing from a research perspective that I hope to be able to prove that I don't think matters in the way that I think other people do. When I feel like if I make a medial release and then I stress it in extension and it's stable, and then I bend the knee up and I put it in valgus at 90 degrees and it opens up medially, I used to not know what to do with that. Do I need to constrain this? Do I need to change my, in a varus knee? How often is this going to be a problem? And it was at a time early in my career that I'm like, I don't really know what this is going to do, but I don't really think it's probably worth constraining it. And a lot of those patients went on to do well. And so that's something that I am quantifying now that I hope to prove, that's something, but I bring that up just as a point on something that now I can put some measurable data with that and show that if I get gaps that are 1.5 and 2 in extension, so I'm balanced in extension in my lateral in a varus knee, and then I put the knee up at 90 degrees and I move it into varus and it's 2 millimeters and medially it's 6. I'll leave that alone and I'll just put it and if it's stable anterior to posterior, I won't do anything about that valgus stress and flexion. That to me is a research note that I think I can make a comment on now in the future. I haven't yet, but I believe I can in the future because it's measurable and I can't just say, well, I look at it and I think, well, I think here, this is what I should do. Now I think that's a quantifiable thing where I can say, look at these 40 patients that I took care of, varus knees, balanced in extension, same gap on the lateral side as extension, and medially that they open up after a medial release that I didn't do any kind of increased constraint on that have good outcomes. That's something I couldn't quantify. I couldn't put numbers to from a research perspective without the robotic technology. I mean, that's just one example. But the point is that for me, why do I need it? I hope to eventually eliminate that terminology. I don't think anybody needs it. I definitely didn't need it. You didn't need it. But is it a tool that I can use to try to make myself better? Yeah, I do think it is. And it's more information that I think that I can, if we have access to, or we have the ability to have that kind of information, why not use it?
Well, if you think, Rodney, about the way a lot of people do knees, it's very much it's very formulaic, right? So they put their isothermal cut guide on, they cut off, and maybe they cut off 10 every time. Boom, 10 comes off. A lot of people, very unfortunately, routinely march their guide up 2 millimeters and take 12 off. I know a lot of guys that automatically take 2 off, which is just awful. And then they take 10 off the high side, right? So if it's a varus knee, they put their stylus on the lateral side, mark 10 and cut it off. That approach to a knee ends up with, oh crap, 15% of the time, like big polys or whatever. And ROSA, for me, that going back to Scott's question about why I need it, I know now ahead of time, ROSA, like other systems, ROSA is not unique with this. It quantifies the laxity of the gap ahead of time. I tell it the cuts I'm going to make. It says, look, here's what your gap is going to be if you make that cut. And there are times when I'm making really, really minimal cuts in the total knee now. Not all the time, but I'm occasionally taking 5 off the tibia and 8 off the distal femur and ending up with a 12 poly that's well balanced. So,
well, you're exactly into my next questions, which what have you noticed has been different about your technique, about your resections in particular? I was somebody that with the training that I had in New York when I did my fellowship, Gil Scuderi would measure every resection to the millimeter with a caliper on every resection that we did on every total knee. So when I came out into practice, I started measuring every resection that I made. Early on in my career, I started having some people that were tight in extension early on. So I changed it. If I got 9, I'd say, you know what, I need to make sure I get 10 or 11 with that specific system and my specific technique in order to get the extension better. And I used that data that I caliper measured to change my technique. And I felt like I was able to take care of that problem through those measurements. So I caliper measured this for probably, I've done probably 2,500 total knees over the course of 11 years. Around 2,500 of them, only about 150 of them have been robotic. And I think that one of the things that I would tell people if they're going to start robotics, before you start robotics, utilize your current techniques and caliper measure your resection. And then when you start to implement robotics, see if there's a difference. And to me, I have noticed some difference in resections there, and you kind of alluded to it. I feel like I take less bone posteriorly off the femur, and I end up with larger sizes. I think larger size implants that I did before. I haven't looked that up yet to see for sure if there's a difference, but I feel like I put in more 9s and 10s and less 7s and 8s, and then I have smaller posterior femoral resections. And I would never have accepted some of the resections that I get from the robot previously. If I would have put my cutting block up there and I would have gotten 8 and 5 on my posterior, 8 medial, 5 lateral on my resections, I said something's wrong. This doesn't make sense, because they're usually 10 and 7 or 11 and 8 or something more along those lines. But now that I have that information and the balancing data that goes along with it, with the gap balancing technique, like you said, I was more of a lean measured resection surgeon with total knees. There were some times that I thought, if I take that full 12 and 11 and 8 like I normally take, I'm going to be really loose. I'm going to be 4 or 5 millimeters looser in flexion in a way that I never would have thought I would have been. And there's the other way too. There's been some times that I've thrown it up there and it said that my tibial resections are going to be 5 and 10, 5 medial, 10 lateral on a varus knee. Like, I would never have taken that much bone without the gap balancing data that the robot provides. I would have taken 2 and 7, and then I would have recut, and then I would have been at 4 and 9, and then I probably would have still felt like I was too tight, and then I would have marched my way down, which of course I'd much rather take not enough and march my way down than the opposite. But with the robot, sometimes now I say, you know what, I'm going to have a 10-11 insert here, even though I'm taking 5 and 8 on my tibial resections, which is not a resection that I would have ever gotten before.
But that's where, in my opinion, the power of robotics is recognizing that knees are more individual than we thought they were. that knees don't behave, they don't always follow a particular paradigm. And like you mentioned, the varus knee, I've called it the crisscross knee, where it's paradoxically loose medially in flexion, or the valgus knee that's loose laterally in flexion that requires component change, or you're going to end up with a really weird flexion gap. And in my previous life, if I got a weird flexion gap, I'm like, what you said, like, well, do I constrain this? I'm not going to put in a revision knee. Or do I do this and cross my fingers and close it and say whatever dumb things we say to ourselves, oh, it'll tighten up, or oh, there'll be whatever we say to make ourselves sleep at night.
That's all my favorite. That's always my favorite. The loose ones will tighten up, the tight ones will loosen up, and the ones that we put there where we want to, those are going to stay.
Yeah, exactly. Right. So being able to recognize at the beginning what's unique about that person's knee and then react to it. And then the other thing is and this is, so everything we talk about, and I may be moving us into a different spot, but this is important. Everything up until about a year ago has been anecdotal, right? So somebody gives a talk about robotics. Oh, my patients do better. Well, that's anecdotal evidence. So what does that even mean? Well, I mean, I don't know, because you guys do more research than I do. While I'm collecting Coos Junior scores, I'm not comparing them, I'm not doing hardcore research. So if I tell you my knees are doing better, that's just anecdotal. That's my gestalt or whatever. But what I've noticed is when I plan knees, so going back to measure resection, the gold star was a 6-degree band of alignment. $3. And if you ended up at 3 degrees of varus, you weren't doing that on purpose. You were shooting for neutral and you just fudged into 3 degrees. So you landed there by accident, right? But now we can take a deformity and we can purposely place people in that band and go, you know what? I'm going to leave you're a 20-degree fixed valgus knee. I'm going to leave you in 5 degrees of valgus or whatever. And we all have our own limit as to what's acceptable. But I've started, and my limit of what I did was 3 on each side. Now it's maybe 5 on each side. Some people are 6 or 7. But I'll leave people in varus or valgus, and I rarely do releases anymore. Man, my early life as a measure resection guy, you remember a terrible varus knee taking however you did it, a half-inch curved osteotome,
I still do.
Their freaking tibia, and you're like, oh my land, I'm going to screw their MCL. And I don't know how often I do releases, maybe 5% of my cases, because I'm using the varus valgus swing and minimizing soft tissue release. Okay, so everybody has supposed that that's a reason. Well, there was a study that came out. It was published in J. Arthroplasty last October, and it was with the Omnibot. So it was with the Corin's robot, where they took 2 groups. Do you remember? I don't know if you remember the study.
I remember.
One group was the measure resection group. Everybody's cut the same, and then then they soft tissue released their way to happiness. The other group, they took everything, measured the gaps, and changed the cuts to leave them in varus or valgus and minimize soft tissue release. And then they did PROM scores for 2 years. And
I do remember this study. We reviewed this at one of our meetings, Scott.
Yeah. So the group that minimized releases by playing with varus valgus alignment did better all the way 2 years later for PROMS data. And I was like, okay, everybody has been talking about that. And to me, that's the first study that started like, okay, here's laying down some evidence that this is what's good about it. That's where the benefit comes in. And you've talked earlier about you want to do, if you're going to change something, you want your patients to do better. And now that's evidence. And it's bringing us back to what I was hoping for in 2006. How do I know where people want to live? How much varus, how much valgus? And I think that's a better shot at it than I've ever had, being comfortable knowing that I can put somebody in some varus or valgus and help them do better.
Yeah, and as a counterpoint to that, I'm still more of I'm shooting for 0 every single time. So
you are interesting. Okay,
I am. I'm still, like I said, I'm insole trained. I'm trying to put every knee at 0, and I don't move one way or another. That's one thing when I went and watched somebody do these for the first time. Trevor Bank up in Michigan. I observed him, and he had a knee that was just a couple millimeters or just a millimeter or so from being balanced, and he shifted his tibial component into like 1.5 degrees of varus. I mean, barely any adjustment at all to make it balanced. And I'm like, that is not how I would have done that. and so it made me kind of, and I still don't, but I don't, not because I think he's wrong. I just think I think I'm kind of waiting like you were. And where's the data that shows us that this is going to be okay? For me, it's the long-term concern. I don't doubt and have never doubted that if I take somebody who's varus and leave them in varus, they're going to feel better than if I try to correct them to neutral, at least in the short term. Never denied or thought opposite of that. My question is, if we leave somebody in 3, 4, 5 degrees of varus, which, if you try to leave somebody in 3, we're going to leave some people in 5 or 6, and we're going to leave some people at neutral. That band that we miss by is going to still miss by about that much. Our target's just going to be different. So, if you leave somebody in 4 to 5 degrees of varus, what's that going to mean in the long term? So like we talked about earlier, I'm a little more of a slow adopter, and time will tell on that. But those kind of studies, the one that you're referencing, I wish I could remember who it was so I could give him credit for it. But that's the kind of data that I think we need in joint replacement right now.
What's interesting about the fear of alignment, right? The fear of alignment is we want to load things perpendicularly so they don't fail, right? So the big fear was thou shalt not varus, for the fear that a varus construct would fail. Well, we all know from experience that femurs don't fail very often, tibias fail. So now if I put a bunch of x-rays up and got a bunch of people with your experience and my experience, and they were all, one was perfectly neutral, one was off by, one was a degree of varus, all the way up to 3. I don't know when people will start noticing the difference visually, but it might not be until about 3 degrees of varus that you start to notice they're different. KA guys put tibias at significant degrees of varus, right? I don't do that. When you see my film, they might be in a little bit of varus, but I've got a pretty, I'm still stuck where you are, and maybe stuck's the wrong word. I don't want to take the tibia very far away from neutral. So I'll maybe go a couple of degrees, right? If I go 3 degrees, that's a pretty extreme day for me.
Which of course begs the question, though, like if we think that those people feel better leaving them in that alignment, why are we scared to go past 3? Right. I heard Tom Faring say the same thing in a meeting once, and a guy that I really respect a lot, that I listen to whenever he's talking to meetings, he said, I think it was him, said, I'm good at 3. I don't really want to push past 3. That's why I guess I'm just not all in on the kinematic Kool-Aid yet, is because if you think it's better, then go for it. Like if it's only better within a certain amount of bounds around parallel and perpendicular, then it sounds a lot like what I'm saying, which is that everybody should be parallel and perpendicular. We've gotten off track here. Another question I wanted to talk about was efficiency. The big worry and the data, again, settled science, I believe, of computer navigation was that it added time to your case. It seemed like every study showed that it added time to the case. And what's your experience like from an efficiency and time standpoint? Okay,
so initially, obviously, ROSA cases took me longer, right? I mean, I don't know how much longer, 10, 15 minutes as I was adjusting to everything. And it's such a mojo switch, because my PA's moving around and get in the way of the robot, and how do you get out of the way of the arm, and how do you do the planning screen? But when I got to about, 20 or 30 cases, and I was pretty close to what my prior tourniquet times would be, I honestly sat there and thought, okay, I'm not time neutral yet. This is maybe 20 cases in. But I was feeling so good about what I was doing that I concluded I didn't care anymore. So I didn't care at 20 cases that I wasn't time neutral. Now, eventually I got to where my tourniquet times were before. And I don't know what's been happening, so I'm about 700 ROSAs in now. About the last 3 months, my tourniquet times are dropping. But I really honestly don't care about tourniquet times as long as they're reasonable, right? You can't do a total knee over an hour, and this is my opinion, and you can't do a total knee in 20 minutes. I mean, that's just my feeling. So if I'm looking for somebody to do my knee, and the first thing they tell me is that their tourniquet time is X minutes, I'm not going to pick that person to do my knee, right? Knees are fast if they're fast, and they take a little bit of time if they take a little bit of time. So that's a very windy way to answer your question. So am I, the efficiency piece, is it more efficient than standard instruments? No, there's no way. When I'm bouncing rooms around, and if I have to move the robot, it's not more efficient that way. Is it more efficient because I open fewer pans? Maybe a little bit, but not enough, in my opinion, to make a big statement about it. And then is it faster? No. Is it time equivalent? Probably. The problem is when surgeons come into robotics, and if all they want is speed, then I don't think robotics is for them.
No doubt. I agree with you there.
Because robotics, and Rodney, and I really think, so in the 3 years I've used robotics, I've learned more about total knees than the prior 17 years. I have no doubt about that. Because robotics, and this is where there are some companies on the market that hurt surgeons, where if a company facilitates a robotic case so you don't have to think about it, right? If the company rep is in the room and running the planning screen and planning your case, I hate everything about that, because it arrests the surgeon's understanding of robotics, and it doesn't let them get deep into the really beneficial weeds of robotics, right? So surgeons that really want to learn and really use these machines for what they can do, man, that's where all the power is. And so surgeons, they have to come into robotics and want that, and then understand that's going to cost something. And the cost is going to be, it's going to take you longer at first, and it's going to take you a bunch of preparation to get into it, and you're going to have a learning curve. And if you can be cool with that, then it's all gravy after that, in my opinion.
I used to think that the people who needed this were I always thought the conundrum with robotics and computer navigation was that the people who needed it were people who were lower volume surgeons who didn't do as many of them, and they were the ones that were least likely to spend the excess cost that it would take for their hospital to buy a robot. I thought, well, I'm a high volume surgeon, you're a high volume surgeon, we probably don't need it. And because of that, we're the ones that would probably be able to justify the excess cost the most, because we have a higher volume, but we're the ones that don't need it because we're so good, because we're these, we're fellowship trained and all this stuff.
Right.
Over time, I kind of got off of that high horse a little bit, I think, to realize that, the data is pretty clear from conventional instrumentation that we're off a hell of a lot more than we think we are off, and a hell of a lot more often than we think we are off. And that this has definitely tightened the curve around alignment for me, and I think for everybody, which navigation's told us that. I think it's also tightening the curve around ligament balancing. I think it's tightening the curve around slope. I think it's tightening the curve around everything. Where for me, as someone who does a lot of knee arthroplasty and most of what I do, I still feel like it's definitely something that's been a big improvement for me.
Agree. And one of the benefits of a system like ROSE is it's constantly gathering data, and then it feeds if the surgeon's using the data, pairing with it the My Mobility program that collects PROMS data before and after surgery, and serially as they recover. Zimmer's investing a ton of money to start helping us finally figure out like what really works. Maybe everything works. Maybe what philosophy is better? Is KA better? Is a hybrid version better? Is whatever people are calling restricted KA or physiologic alignment, whatever people are calling it. So it's going to be fun to start seeing what happens when high volume, serious minded surgeons that are willing to learn, right? That are willing to go to like you just said, right? Come to the table and go, listen, okay, first of all, I'm willing to drop all of my sacred cows if it's better to drop them. Like, yeah. I'm open to doing this differently, and I'm open to learning. So you take a high volume surgeon that's got 10 years under their belt, like you, and that comes and goes, hey man, I am willing to learn and change my mind if it's reasonable to change my mind. In other words, I'm not going to come to this and impose my philosophy on the robot. I'm going to see what happens. And if I don't need to change, I won't, but I'm open to changing.
I think a lot for some people that amount of data is intimidating. I think I think some reps that I've had that are seeing it for the first time with me, medical students when I have in there, when I'm going, all right, take that up 2 millimeters, take that this way, take that this way, take that way. All right, go. They're like, what the hell just happened? And so I actually did this today in a case. I stepped away. I walked over. I'm like, come here. I'm like, see that number right there? That one's 2 millimeters different from this one. That's why I'm moving this here. So then I had to move it. And I think, and nothing against surgeons, but sometimes surgeons get in the role of this. I take this much from here. I take that much from there. This is how I do it. And they don't nerd out like you and I do on the little details of, if I rotate this much this way, if I take a couple more millimeters here, that I'm going to do that. And actually, the amount of data that it gives you can be intimidating at first. But again, I wouldn't want to go back now that I have that kind of data. That's the part that's been really fascinating and interesting.
So, Dr. Ballard, my background is physical therapy. And when we see these patients after surgery, as we started to transition to the robot, when Dr. Benner was doing this for the past year or so, with your experience in doing this, sending these patients to rehab afterwards or physical therapy post-operatively, are there any changes that you are making because of the robot, or are you seeing any different objective rehab measures that are either better or worse with your patients now that you're using robotics?
So the key question you asked is objective measures. And being in private practice, I don't have any, objective measures, meaning I'm not studying this. I'm not collecting and comparing the data points. So to be honest, a total knee is a very insulting operation to the leg, right? We can't get away from that. And anybody that tells me, okay, this is my personal opinion, does robotics make things totally easier for somebody? It doesn't. When patients come in and they go, oh, you're doing this with a robot, and they have this idea it's going to be easy, I'm like, no. This is not going to be easy. Recovery is going to be very hard. And so do I get a perfect case off the table? Yes. And does somebody sometimes come in and their rehab has not been perfect? Absolutely. So do I still get people that are struggling to get full extension? Yep. Do I still occasionally have a manipulation? I do, because you can't change humans, right? And so much of knee recovery is based on how the person approaches pain, how they're put together psychologically, what their social support network is like, what the effort they put into therapy. And you as a therapist know that better than anybody. Do I think that I get a knee off the table that's the best product that I can get off the table? I do. Do I think that, and now we have the science behind it, that minimizing release is better? Yes, because I'm not giving somebody a grade 3 MCL tear like I was before by jamming an osteotome down the inside of their tibia. So I think it gives them a better opportunity to do better, but I would not sit here and tell you like, oh, the recovery difference has been magical, because I think that would be disingenuous. It's still a really hard operation to get over, and there are still people that will struggle no matter what we do for them. Now that's, of course, I'm saying that, but and Rodney will tell you that when we think about that question, our mind goes to our problem patients, and I'm forgetting the 15 people that walk in at 6 weeks and are doing this and doing great, and we don't tend to focus on them. So I do get people that are doing ridiculously well. Their recoveries are short. I'm just kind of in a mode 20 years into my practice that I don't over-congratulate myself.
I'm with you on that as well, because you hear some pretty interesting claims when you talk to people who are trying to sell robotics or who have been doing robotics, and they're trying to convince you on it. Oh my gosh, I had people coming in sometimes, they're all the way straight, they're bending to 120 degrees at such a quick time point. And I'm with you that I'm much less likely to make outlandish claims with regard to range of motion. If you've listened to any of our podcasts, you should know that we are crazy about range of motion as it relates to sports medicine topics, but also as it relates to arthritic knee care and total knee replacement. So we measure range of motion every single patient that we see every single day, and one of our therapists quantifies it with a goniometer, measures it to the degree every time we see the patient. So we have an avalanche of range of motion data that I think as time goes by, we're planning to query to see whether it makes a difference early on after surgery. Does taking that person that I used to take, 10, 11, 12 millimeters of posterior femoral bone, and now I'm taking 7 or 8. Does that make a difference? Does that make them feel more normal? And does that improve their flexion, even though we've taken, theoretically that may result in a tighter flexion gap? Is that tighter flexion gap more balanced and then able to still have a better amount of flexion? Or does that tighten them in some way, restrict their flexion? I definitely don't think that's the case. But the point is that I do think that's something that I think is an important thing to be able to give us quantifiable physical therapy data with reproducible, measurable techniques that I think hopefully we'll be able to comment on in the future. My own confirmation bias of me thinking that every patient that does well is because of robotics, and every patient that doesn't do well can't be blamed on robotics. We all fall into that trap, but the data will answer those questions for us.
Now, seeing these patients initially post-op, we're fighting swelling for the first 6, 8, 10, 12 weeks even, and that, as everybody knows, will really limit their flexion. Now, when you're talking about taking less resections or limiting balancing procedures, is there at least a theoretical benefit of reducing swelling? I know you said total knees are an insulting type surgery, which I would completely agree with as well. But I know we talked about efficiency being about time neutral, so we'll take that out of the equation. But especially when it comes to something like ligament balancing, if you feel like you're not doing that as often, do you feel like there's going to be less post-op swelling to the point where you could get some acute gains in motion?
That's a good question, and Rodney would probably agree with me. I think the insult of this operation isn't necessarily the posterolateral corner release I'd have to do in a bad valgus knee, or the posterior medial release, or the deep MCL release in a bad varus knee. Avoiding those things, I think, is helpful, but the insult, I think, is in the bone cuts when they go into extension and they get a controlled tear of their gastrocs, or, those things I think are the true insult. So it does help that we're not damaging the medial and lateral structures as much with releases, but I still think the main driver of the inflammation is just the anger that this operation, the insult this operation is to the leg. And I don't know if those releases do a lot to minimize that crazy inflammation that people can get when they come in and they're super swollen.
Yeah, I mean, from a swelling perspective, specifically, I think the bigger releases that you do on the medial side, which I do, you're talking about doing medial releases with an osteotome. That's how I do them every day. And I think that does result in more bruising down the leg, not necessarily more swelling in the knee. For me, the improvement in swelling has been getting rid of the tourniquet, not getting into robotics. My tourniquet time hovers around 0 on average. So I have not noticed the difference in my tourniquet times over time, because I don't put one on. I don't use one anymore, and have abandoned that completely. I feel there's definitely more intraoperative bleeding, but I don't feel like there's as much postoperative swelling, because the bleeding has largely already happened and stopped by the time you've had the knee open for the whole time, and using TXA has been a big important part about that as well. So I don't know that robotics is really changing that much. I guess I'll take that back as quickly as I say it. Not cannulating the femur, I think does result in a little bit less diffusion as well, by not putting a rod up inside the femur. I used to stick a bone plug up there, and sometimes I'd get a perfect little press fit and go, wow, look at that, that looks perfect. Sometimes I would stuff half of my anterior chamfer section in there, like, well, that's not doing anything, but okay, I guess we're moving on here. I do think that makes a little bit of a difference.
It's funny you brought up tourniquets. You guys did a podcast on tourniquet use, I saw, so I'll have to go back and listen to that. But that's a topic for another day.
Yep. As you wrap up and kind of summarize your thoughts on this, what would be kind of those key take-home points that if there's somebody who's listening to the podcast that hasn't tried robotics, what would be a couple of the main points that you really want them to take home from this discussion tonight?
I think it's in listening to you and I talk, we're two surgeons that, like all of us, care a lot about patients. We love this operation. We deeply respect the complexity of this operation and the individuality of each knee, right? And we were both incredibly reluctant to approach robotics. We both kind of went kicking and screaming to different degrees to this. And to have two complete skeptics that don't have a dog in the fight, right? I didn't design Rosa. I didn't design any of this stuff. I don't get paid to talk about, I don't get paid to use this, royalties, whatever you want to say. I'm pretty neutral about that. And I can't imagine doing a knee without it. And if you took Rosa away from me, I would pick another robotic system and take the same techniques to it. So if you're skeptical, I think that's because you're smart and you're careful. And I think it's very healthy to be skeptical. But I think you should be, I frequently tell people that I'm open-minded in a closed-minded kind of a way. So you should take your skepticism and look into robotics and prove it to yourself, and take that leap, because I think, like a lot of us are showing, you're going to learn. You're not just going to learn a lot more about total knees, and a lot of people have told me this, and you commented on this earlier. My enthusiasm for total knee replacement has gone way up. My interest, the joy of approaching this problem has gone way up as a result of Rosa, and I'm much more engaged in it. Mm-hmm. Did you find that?
Yeah, I mean, I was, from a research perspective, it was kind of mind blowing to me, the amount of data that we were getting out of this. One of my former reps who left our local area, moved on, and was a part of the team with Rosa, would send me a screenshot of him scrolling through not the patient information, but just the amount of data, and he would scroll down all the measurements that people make, and I'm like, man, that is that's awesome. I said, what are people doing with that? He said, they're throwing it in the trash. They're using it somewhat during surgery. There's a lot of it they're not using, and then from a research perspective, click delete and it's gone, and it hurt my feelings. It hurt. It hurt my feelings when he would show me that stuff. We've had a couple meetings recently about what do we want to. How do we take all this data, all this mass of numbers that we have? What are the ones that matter the most? What are the ones that we want to focus on from a research perspective? Because there's a lot of stuff that I think, I don't really think we need this. I do think we need this. For me, it's just a lot of data and a lot of information that I think, while it may be intimidating to people that haven't used it before, if you haven't thought about knee replacement in that level of complexity before, if you're wondering how can I get better? Why do I have X amount of percentage of patients that aren't happy? And know, for me, if that's where you're at with it, to know that there's all this other information that's out there that you can have that may unlock some of those answers for you. I think that's really exciting. And for me, like you said, I'm a data nerd when it comes to total knees anyway. And the ability to have all the extra data that we have from robotics has made me, I do think has made me better. And it definitely has. There have definitely been subtleties where sometimes I make cuts and I measure them and I look at it on the screen and everything balances. And I think, man, I would not have done this knee in this way. Yep. Had I not had the robot. Maybe I still would have had a good outcome anyway. I don't know. Maybe I would have still had a bad outcome anyway. Time will tell.
I would tell people to stay skeptical if you're skeptical, but open your mind and start looking. Looking doesn't hurt. Go to a lab, take your favorite knee system, pick the robot that goes with it. I have experience with Rosa, so I've got a bias towards the usage of that robot, of course. But if you're going to use a robot, learn everything about it and run it yourself. And don't let anybody plan your case for you. Learn it, use it, be the only person in that room that's the master of that planning screen. And I think it'll change your practice.
I think I was a pain in the butt with the reps that you were there that day when they were kind of going through that stuff with me. I stopped them about halfway. I'm like, fellas, hold time out for a second. You weren't at this point, but I'm like, fellas, I don't need you to tell me how to do the operation. And I don't say that from a place of arrogance. I'm like, I'm not here today to learn how you think I should do the operation with the robot. I'm here for you to tell me to work with me on how do I do my operation the way that I want to do it, that I know how to do it the best way with the robot. It's also a conversation I have with patients a lot. I always make the joke that, like, so you're using a robot to do my operation? I say, yeah, I sit in the corner and drink Diet Coke while the robot steps its way in and does your operation for you, and they laugh. But then I say, you know what, really, you have to think about it is it's just a tool to do your operation. I used to use a different set of tools. Now I use a new set of tools. The robot only knows what I tell it. The robot only knows what you tell it. It only adjusts itself. If you tell it to adjust itself, it's just a tool for us to do the operation. The one thing I would say to anybody who's listening that's thinking about it, if you're thinking about a switch to robotics, before you do it, start caliper measuring your resections and try to figure out what kind of thickness resections you make on a regular basis, because the ROSA pops up, or the robot puts up a lot of data of, you're going to take 9.5 here and 9 here, 12 here, 9 here, this amount of rotation here, this amount of resection here. And if you've never looked at those things and measured your resections to know what is my normal distal medial femoral resection, you don't know that, all of a sudden you have all this information, and how do I put that into context with what I've done in the past? So take a bunch of cases and measure your own resections, kind of come up with that framework in your brain, and then use that when you go into robotics. Dr. Ballard, thank you again for joining us tonight and taking some time out of your day, and for coming on. We really enjoyed the discussion.
It's been great, guys. Thank you for your time.
As we talked about before, you can find Dr. Ballard on Instagram at rock_orthopedics. That's ROC_orthopedics. on Instagram or the Rock Orthopedics Facebook page. He also has his own website as well, and that is jamesballardmd.com, where you can go and learn more about him. If you want to catch our social media outlets, we are at the SKC Podcast on Twitter and Instagram. We also have the Shelbourne Knee Center Podcast Facebook page. We also have a YouTube channel. And wherever you get your podcasts, hit that follow button so you can catch all of our content every week and leave us a comment for people that come behind. Thank you all for joining us again, and we'll talk to you next week.